So this is about the pulmonary hypertension, and as we know, this is a very common cause for the breathlessness. Now, if we talk about the breathlessness, then as far as the respiratory thing is concerned, the breathlessness can be opted out for any patient who is having asthma, who is having COPD, and in cardiac, maybe the cardiac failure. This is I'm talking about the breathlessness on an exertion. So, but sometimes what happens, we are quite confused, like what is the reason for breathlessness, and we are not able to find out the answer for this breathlessness. And in that, this evaluation, many a times we found that actually the pulmonary hypertension is the reason for that breathlessness. And I'll start with my just a simple, these are my reference for the presentation. And I'll start with simple case. Case is not like, this is just how the patient normally presents to us. So she was just a 40-year-old. This is a real case scenario, but the female homemaker resident of Delhi, and she presented to us with the progressive dyspnea on exertion. And she was initially diagnosed with the asthma, prescribed steroid inhaler, somewhat dyspnea improved, but still the dyspnea did not get better at the level. And then after some time, the dyspnea again started, the progressing. She didn't have any comorbidities, and the BMI was not that much. I mean, 22, that means we could easily rule it out, the obstructive sleep apnea, OHS, or many things that is related to the obesity. So basically, even she was not having any history of smoking. So young female, almost 40-year, diagnosed with asthma, maybe because of some family history was there, and was having this breathlessness on exertion, but was not getting better with the inhaler. And what happened after 7 months of this starting of the inhaler, she actually presented to the emergency with the history of a syncope after rapidly climbing flight of stairs. So this, I'm just giving an idea like how these presents, these patient can, the presents. And when we did the workup in the emergency, the ECG showed the P pulmonary lead to, the echo was, the pressures was a 57, this the PASP. X-ray was normal, the CT clearly showed the enlarged pulmonary artery. And then we finally went into the family history, and we could understand that the reason probably is a pulmonary arterial hypertension. And this was, there was a significant, I mean, the family history was also positive for the pulmonary hypertension. She was taken care well after that, and she responded very well, to the treatment. So, this is normally how these patient presents to us, and we often miss this pulmonary arterial hypertension. So just to summarize very quickly, like who are the all patients where we need to screen it, where we need to think that the pulmonary arterial hypertension can be there. So family history is very important, and if you will look for it, then definitely you will know it, like, because the presentation in a pulmonary arterial hypertension mostly is a syncope. Even, in the family history, you could ask, like, is there any history of a pulmonary arterial hypertension or any history of a syncope in family? I mean, this could also be the reason for the pulmonary arterial hypertension presentation. Systemic sclerosis, very important connective tissue disorder. It very oftenly presents with the PAH, and sometimes the pressures are high. We doing the echo as a routine, or maybe by some other reason. And then we found that the pressure, the pulmonary arterial pressures are high, and we don't have clear-cut reason that why the pressures are high. We don't have, the patient does not have any heart disease, he does not have any lung disease, the patient does not have any thromboembolic disease, but still the pressures are high. So just keep your eyes open, your mind open, that it still could be the pulmonary arterial hypertension. So I'll tell you the difference between the pulmonary hypertension and arterial hypertension. The pulmonary hypertension is a big, the thing where we can include the arterial hypertension, we know occlusive hypertension, maybe the thromboembolic phenomena. In a broadly, this pulmonary hypertension is divided in 5 groups. The group 1 is arterial hypertension. This is what we are concerned about. This is where we need to give the treatment. This is where we need to diagnose this disease as early as possible so that the outcome can be different. In group 2, the hypertension is due to heart disease. It may be the left ventricular systolic or a diastolic dysfunction, or maybe some other valvular diseases. In group 3, the reason of a pulmonary increased pulmonary pressure is in the lung. So the PAH or PH due to the lung disease is comes into group 3. Group 4 is a chronic thromboembolic phenomena, and group 5 with the multifactorial disease like hematological disorders, as I told you, the sarcoidosis, histocyocytosis, multiple metabolic disorders. So you need to understand, like, these 5 group are group of a pulmonary hypertension, and we are mostly focused today would be the pulmonary arterial hypertension, because in other terms, if we talk about the pulmonary hypertension, then in group 2 to group 5, we need to treat the primary disease. This is the most important thing that we need to understand. Is for the guideline, it is not like that every time whenever we have the pulmonary pressures high, we need to give the medicines for PAH. No, we need to first finalize that this is a PAH, and then only we need to give the medicines. So this is just a new diagnostic criteria to define the pulmonary arterial hypertension. And as per the revised definition, as I can show you on a slide, the pressures they have reduced from 25 millimeter of mercury to 20 millimeter of mercury in revised definition. They are giving importance to pressure, because even if the mean pulmonary pressure is more than 20 millimeter of mercury, you need to see that something is not going good. And over the time, if you don't treat this, then the pressures will increase, and the overall, because the issue with the pulmonary hypertension is that the patient is not able to walk. And we check the heart is okay, we check the lung is okay, and we're not getting any information that why the patient is breathlessness. So the tech point is, like, any breathlessness on exertion, we need to keep our eyes open. Are we dealing with the PAH? And this is as per the new guideline that I told you. As far as the epidemiology is concerned, obviously it belongs to group 1. I already told you that we have group 1 to group 5, and the incidence is not less but 15 to 60 per million. I mean, this is a significant amount. It's not like very low and rare disease. So the PAH, it's still possible in patients, and the 50%, almost 56% have symptoms with minimal activity. This is normal presentation, because we are diagnosing this pulmonary arterial hypertension actually very late. And as per the recent data, the delay from the symptom onset to diagnosis in PAH cases is almost equal to 2.5 years. Because initially the patient is being evaluated for the asthma, sometimes the COPD, sometimes we don't care about what the pressure, maybe the pressures, and at the same time we need to look for, like, even the echo. It is totally the objective subjective appearance, and sometimes we do the echo from one cardiologist, the echo pressures are like 30, the other cardiologist sometimes they make it a 40. So I mean, it's better to do the same setup, the echo repeat, so that we can exactly have an idea. And I would say, like, everyone who is doing this echocardiography to focus, like, if you are measuring a pressure, just do it subjectively, so that the pressure can be, the exact pressure you can tell to the patient and the physicians. These are the normal signs and symptoms of a PAH. Normally, they, as I told you, presents with the dyspnea, and actually not dyspnea, it is a dyspnea on exertion. Any dyspnea on exertion, this we need to, if we don't have any other explanation, we need to think about the PAH. The patient may present along with this the letharginess, the fatigueness, exertional chest pain, some abdominal pain, because if the disease is further increase and the going towards the increasing pressure, the signs are like we need to see the wide split S2, some murmur, tricuspid regurgitation, we can see the elevated pressures and hepatomegaly and the leg swelling.